So we have America's Heart Healthy Doctor here, Dr. Joel Kahn, a good friend of mine, and a previous guest on the show. I'm going to jump right in. I just want to ask Dr. Kahn, it's the new year. In my sense of things in the lipid world is that the low carb community is winning hearts and minds. You know, I've seen you were on Rogan. You've been featured in movies like What the Health and The Game Changers. And there was a huge push a few years ago where there was a very heated and hot debate with the low carb community versus kind of the plant-based community. And my sense of things is that the low carb community is kind of winning hearts and minds right now. Where do you see it?
Well, I think you're right. In the last 5 to 10 years, if paleo tends to be, quote unquote, low carb, ketogenic had a good run, low carb. And then, the last 5 years, we're getting knocked over the head with carnivore diets and carnivore people. I mean, I don't think you could fill my fingers with important studies in the last 12 months supporting low carb. And then there's been a few defectors. I don't follow Paul Saladino, a psychiatrist who got rather big on social media for being outrageous and somewhat ripped for his carnivore diet views. I think also in 2018, the year I was on the Joe Rogan Experience, I did a lot of shows for the Doctor's Show. People remember that. And Saladino and I had our moments together. I think we mainly debated the 1 meal a day diet, the OMAD diet or the warrior diet, but he was going bonkers crazy. He's backed off and he's, didn't feel well and he's varied his diet. It's like the first defector from a physician who wrote a book about the carnivore diet. So, the price of meat's gone up. Nothing, wonderful has really been discovered about meat. In the last 7 days, I think specifically the last 2 or 3 days, one of those famous nutritional epidemiology studies, Harvard School of Public Health, on the influence of processed meat and overall red meat on dementia risk. When you're dealing with almost 200,000 data points over 30 years, so really million of patient years, and you see a 33% increase in dementia risk in the heavier, for sure, processed red meat eaters. And I know the pushback always is, but it's not grass-fed, grass-finished, it's not organic, it's not free range, it's, all the words we can describe, although, it's uncured bacon versus bacon. But when you get down to it, America that's eating processed red meat and America that's eating red meat, it's typically, what they studied in this most recent Harvard School of Public Health publication that, made headlines. So, red dye 3 got booted out. It'll take a year or 2 to completely get it out, but it's going to be a drop in the bucket. Red meat is a big issue. Added sugar is a big issue. Dairy,
right, but it's a big issue. But the thing is we these are drums that have been beaten now for quite some time, and it seems like the population is headed in the opposite direction. And as somebody like myself, and when we chat, I see ApoB as kind of the North Star. It's like I want to talk about the Nick Norwitz YouTube videos because he's a very interesting content creator. When we interview dietitians to come in, we're going to have dietitians, to consult with the gene food user base. And you ask them, we want dietitians that are pretty allopathic when it comes to ApoB and LDL-C. That's the mission, and that's the messaging of gene food is we're trying to optimize cardiometabolic health. Dietitians will very casually say, well, you show me elevated LDL-C, I want to see the subfraction. I want to see the particle size. I want to see, ones that are more sophisticated. What they're parroting is they're basically parroting Dave Feldman's lean mass hyperresponder triad, large fluffy LDL is not dangerous. When you're insulin sensitive, your triglycerides are low. But that flies in the face of Alan Snyderman and people that are not on YouTube who are very credible talking about the ApoB is the governing principle. If ApoB is elevated, large fluffy doesn't save the day. How can people like yourself who have large audiences change the messaging to get people into the church pews here, as it were, for this better side of the argument?
Yeah. And what I think we don't know is if we took a sample of 1,000 people in a movie theater and said, how many of you in the last month have listened to a podcast on nutrition, read a blog on nutrition, watched a YouTube on nutrition, it's under 10%. People are just in their lives, buying their food, and they're not engaged in this conversation. So as far as, is it really a big trend in the United States adopting one of these diets? I don't know that there's data, and I suspect not. The U.S. News and World Report comes out every year with their list, and as typical, the Mediterranean diet was again the big winner. I was honored to be on their panel this year to help select those. I don't know, about 35 of us, but it's an easy middle of the road, selection, and certainly has a lot of support compared to the standard American diet. It's vastly better, but whether it's optimal or not, one observation just to follow up on what you said, I don't feel any momentum that what I've done for, I have to get it right now, 47, 48 years now, being a vegan, and now you want to upgrade that to call it a whole food plant-based eater, because I'm not an Impossible Burger eater. I don't feel the momentum's growing. We're recording this now, it's Veganuary. And because of my social media pics, people I follow, I'm seeing that all the time, but it's not taking over America. We're still 1 or 2% of the population that actually do it full time. And vegan restaurants are suffering. I mean, I used to own one, and for a variety of reasons, I'm out of that business. But New York City, there are exceptions. There's a chef, Guy Vaknin, he's amazing, who now has a chain of 5 or 6 elegant vegan restaurants. And I always script the name 111 Madison, the $400 a person vegan, 3-star Michelin restaurant. But LA, the scene has shrunk. Detroit, the scene has shrunk. I think in New York overall, the scene has shrunk. Very confusing. But, you also don't see carnivore restaurants. Of course, you can get a tomahawk or a ribeye, pretty much anywhere. So I don't know that, I can only say in my own practice, and it's not a fair sample. I think, some plant-based people gravitate to me to see me because they know that I will understand what they're doing and understand their vitamin needs and know what tests to run. I see plenty of just average people, and they're just eating what they're eating. I mean, we got to get them more involved. And, maybe this whole Maha thing, which started with Red Dye 3, which again, I'm only excited that it appears that public action groups can get the attention of the FDA and force their hand. They happen to force their hand about an extremely trivial issue. They need to force their hand about processed food in schools and SNAP dollars going to Coca-Cola and vending machines in hospitals being full of Cheetos. That's what they need to force their hand. And we got a lot of work to do. But maybe this Maha movement will cause a general conversation so that most people in America will be able to speak the language you and I just flow: processed food, hyper-processed food, unprocessed food, whole food. There's clearly, we could change the health of America with teaching people how to cook and how to, grow gardens and how to stop buying frozen food. But there's, God knows we haven't even seen the tip of the iceberg, the pushback that's going to be coming from big food, big pharma, big tobacco, which are all they're so interlinked nowadays. There's going to be huge pushback if there's really efforts to seriously change the $120 billion a year of SNAP dollars. So I don't know what dietitians are advising. I mean, I struggle to find good ones, to refer to, good health coaches to refer to. I agree. A lot of functional medicine people gravitate paleo, and, and they're the ones doing podcasts. They're the ones writing blogs. They're the ones posting on social media. So I agree. You're hearing about it, but I don't think the momentum's going up and up. You got Sean Baker, my buddy, Sean Baker, the crazy 6'6" orthopedic surgeon, and he looks great, and he's stronger than me. And he's, seems like a foot taller than me. We've met, I have pictures, he's friends. But, except for his, through line, straight and narrow, I think there's still, the science is where we should gravitate to. And fiber is king. Color is king. Phytonutrients are king. There's no doubt about it.
I think, you're right. Look, I don't have data. It's just my sense of things. And I could be wrong. I think that part of it with Harvard and epidemiology is that they're getting lumped in with institutions and they're getting lumped in as part of the establishment. And this is a moment, I think, where there's a little bit of a anti-establishment sort of realignment. And so I think some of that advice, especially around LDL cholesterol, with statins and people being prescribed statins and all this is people are looking for alternatives, even when they're not necessarily credible, right? Let's turn. You mentioned you're on YouTube. You're very online. You've seen some of the Nick Norwitz experiments. I wasn't going to bring that up. It does give us a nice point to kind of get into the sitosterol and cholesterol absorption. One of the experiments he's done I've seen on YouTube is eats like a million. I ate a million eggs, and my lipids didn't change and were unaltered. I find those conversations really discouraging, because just knowing the heterogeneity in a population in terms of, you might have one person might absorb 20% of the cholesterol they eat, and another person might absorb 80, and we have the, as you say, the science and the biomarkers and the genetic tests. I think these N=1 experiments are just very unhelpful, but well done, well produced, interesting. Yeah. And fun to watch. So, like, what say you about? Seems you have an opinion. What say you about this kind of new genre of YouTube content?
Yeah, I bumped into Dave Feldman 6-7 years ago. I actually did an episode on his podcast in a rather creepy, dark hotel in Las Vegas. We were both happened to be in the city at the same time. And I started following this conversation of these hackers pushing their cholesterol to 600 and pushing their LDL over 300, then bringing it back down with different calorie ratios. But nobody's brought it to attention the way Nick Norwitz has. And he's clearly, with a PhD, I think it's from Oxford or Cambridge. And,
super, very
bright.
But smart, very well, credentialed.
How many people, how relevant, I don't know if his BMI is 17 or 18. And, he did the study, 30 eggs a day, 24 eggs a day for 30 days, 720 eggs. And I think his cholesterol went down a little because, he does have this unique, triad, as you mentioned, of metabolism. And then the other study that really, I don't think it was very fair, but he went from his typical extremely low carb, high fat diet over to a vegan diet for 1 week. But his vegan diet wasn't a typical vegan diet. It wasn't my vegan diet. It was a very high fat vegan diet. He was packing in. He wanted to keep saturated fat, I think, about the same. So he was packing in foods that can be done, but most people aren't eating and certainly aren't taught by most of the plant-based medical doctors as an option. So his cholesterol went up because he actually lost weight on it. He ate, I don't remember, 700-800 calories less a day for 1 week only on his plant-based diet. And he couldn't afford to lose any weight, but he became even more of a low mass and apparently a hyper responder. It was kind of interesting. I think he had blueberries back and his cholesterol fell. He just needed a little carb in his diet. What does the public hear when they see the headlines in Newsweek about 24 eggs a day or high fat diet? They're getting Dunkin' Donuts in the morning and they're getting Chipotle in the afternoon. They come home, they say, I'm going to eat like Nick Norwitz and throw a whole lot of coconut oil and beef tallow. Beef tallow seems to be the new oxygen right now. It's hot. And it just mixes people up and probably makes them sick. So I think it's great what they're doing. And they have actually done, I don't know if you caught this. There's a very prominent cardiologist at UCLA who's one of the world experts on CT angiography, Matthew Budoff. And they presented a paper I heard about last year, and then they published it in 2024. It wasn't a randomized study, but it was people that had two of the most advanced heart studies you can get, called a heart CT angiogram, looking at your arteries, looking at the amount of soft plaque, hard plaque narrowing. And a group of people who were following a low carb, high fat diet in the lean mass hyper-responder kind of group did not accelerate their plaque over the 5 years. Now, it's provocative. Are there some people can eat that way and not be harmed by it? I think the answer is probably. But is that now public policy that dietitians and My Gene Food and others should say, go for 120, 130, 140 grams of saturated fat a day as a as a new public policy? No, it's crazy because, very few people are Nick Norwitz or Dave Feldman, apparently.
Yeah. I mean, I think that what tends to happen is people follow in the wake of these experiments and embark on just gratuitous amounts of saturated fat, right? Like just crazy amounts. And if you're giving people the advice that, ApoB and LDL cholesterol doesn't matter, I don't know if I really want to be in that position. What I pass on in these conversations, just being a layperson, is, I think if anybody's interested in the energy model, it really works well to go back and listen to the Peter Attia, Dave Feldman interview, because Attia gave Feldman a deep dive on his podcast, and it just didn't go well. Now, if there's new data, then that's actually very interesting. I mean, so let's keep going down that road. I mean, does that make you think that that these people who become dyslipidemic due to metabolic syndrome, insulin resistance with the small dense LDL and these kind of nasty, triglyceride numbers are, all things being equal with ApoB, just at more risk for heart disease than somebody who is, insulin sensitive, low,
Well, yeah, I think my philosophy. There's risk. We've learned a lot about risk. We've got risk calculators. They're expanding. We got ones now that include lipoprotein A. There's one risk calculator that does that, about time. Still, I think there's much more to go. I'm sure we'll have AI-derived, risk calculators. The bottom line is, and this is where the conversation allows a YouTuber or a Instagrammer to confuse the public, not necessarily purposely, is that, I'm a clinician. I see people all the time, and there are people with very bad numbers on paper, and yet do what I say, hashtag test, not guess. And they have minimal or no carotid plaque with minimal or no carotid IMT thickness acceleration. And they have, by some CT imaging of the heart, it could be simple calcium scoring, it could be advanced CT angiography, they don't appear to have disease in their 50s, 60s, and 70s. And that one case study would question the entire lipid hypothesis. And then I'll see a 33-year-old that had a heart attack and has a stent, and life totally disrupted because of cholesterol they probably run since youth of over 300. So you just, unfortunately, I don't think population statistics really help at all. Anybody listening has to know what their carotid arteries look like, what their coronary arteries look like by, very inexpensive calcium scoring. Maybe not at age 30, but I've had a bunch of people in the last month in their late 30s with abnormal calcium scores, sometimes 3 or 18 or 22, but in your 30s, that's wildly abnormal. I just had I won't go further, but a member of Congress, very young man, who had a calcium score in his 20s. The number was in the 20s. He was older than that by a decade, but you have to determine if your biology, which I think we do not completely understand, is creating plaque or not. And if it's creating plaque, you want to be aggressive. If it's not creating plaque, there's a lot more room to be liberal in your diet. Always add fiber and always get your fitness in.
So speak to let's close out on this topic, which is different people coming in. Some people come into the clinic, they're eating this high-fat diet, they show very little in the way of damage. Others, as you just mentioned, lots of damage. Let's talk about LP(a). What's new with LP(a)? Just listen to your last podcast. You mentioned some new research on LP(a) and phytosterolemia, however we want to call it. Because for me, when I think of those two things, they kind of sit beneath the radar for a lot of people in terms of they hadn't necessarily have their LP(a) levels tested, and they definitely haven't had a sterile panel. They definitely don't know what their sterols in the blood look like. So how does this factor in? There's that Wall Street Journal article that just came out a couple months ago about this guy who was ravaged by heart disease because he didn't know that all the nuts and seeds and avocados he was eating were causing problems. Like, where does this factor in your practice?
Yeah, lipoprotein A is a big deal. And it's very much like the conversation we just had. One is very common. 25% of people have a above normal level, and a good 5% of people have an incredibly above normal level, depending on which way you have it measured, just get it measured, everybody listening. But, I got 75-year-olds in my practice with, they're in the 99th percentile for lipoprotein A, and they're free of disease. But then there's the 32-year-old that had a heart attack from lipoprotein A, or occasionally a stroke, or they've got a murmur from aortic stenosis. So you just have to examine everyone individually. It's not hard. It's not expensive. What's new? There was one report associating, this doesn't yet make sense, but enlargement of the aorta. The aorta is a big blood vessel of the heart, with high lipoprotein A levels. And there isn't anything about the molecule that should do that. It does attack the aortic valve, this little 3-part door between the heart and the aorta. And it may be the oxidized phospholipids that like to stick to endothelium, incite inflammation and calcification of the aortic valve. But why it would be related? It might just be an observation that has no causality, but that's the first time it's been reported. There was a report in the last 2 weeks that people that have both high lipoprotein A and intermittent atrial fibrillation it's still early, may be at more risk of clot and stroke. Now, we treat a lot of the people with atrial fibrillation with natural or prescription blood thinners, so kind of takes that out of the game, but interesting association. I mean, very few people still to this day know their lipoprotein A level, believe it or not. I actually think Lifeline Screening added it as part of their self-pay package, which I think is great, and more doctors will start to check it. So, people with atrial fibrillation may want to find out if they have lipoprotein A, but so should everybody else. Absolutely. If you got the family history of of early heart disease, if you've got it, that uncle, aunt, brother, sister, mom, dad, grandparents, early stroke, early heart attack, early bypass, my God, get your lipoprotein A. That's called cascade screening. And I tell my patients with high lipoprotein A, get your family checked. And sometimes they say, no, I'm not going to tell my brother. I don't like my brother. It's kind of funny what comes out. But with that aside, get your family checked. And of course, 2025 should be a big year for lipoprotein A, because we're hoping that this 5-year ongoing 80,000 patient study, 8,000 with a lipoprotein A drug called pelacarsen injected once a month, or a placebo arm, will reveal results. We know pelacarsen lowers lipoprotein A. It's a monoclonal antibody by like 90%, dramatic reductions, 400 down to 15, at the lower ends of normal. But the FDA requires showing that also relates to fewer strokes, heart attacks, and death. And we think in May of 2025, the results of that study may be revealed. There's been no word about safety issues, or if there was a dramatic advantage, they might have stopped the study early, safety monitoring board. So that hasn't happened. I pray that we get a p-value that's, positive. So it's only going to be available, I assume, to the most high-risk people, those that have had strokes, heart attacks, stents, and bypass. It's going to be a very expensive drug. Novartis has put $1 billion into it. And then in 2026, we think Amgen will have results of a similar study. In 2029, Lilly's still recruiting. The other 2 studies have finished recruiting long ago. So it'll be an exciting year. There's really nothing else. I mean, I still use a lot of niacin in my clinic because it works, and I'll stop using it when we have prescription drugs that work better. I use a fair amount of vitamin C, the so-called Pauling theory, which admittedly is largely untested, but intriguing, safe, and inexpensive. So, I mean, but I test everybody's arteries, and if I hear a murmur, I'll test their heart valve. Sitosterolemia, which Dr. Thomas Dayspring beat me up on X and said you should be calling it phytosterolemia, because it isn't just cystosterol, it's the other phytosterols. It remains a very, very rare genetic condition. If it weren't for this Wall Street Journal article 6 weeks ago, probably very few people other than lipid geeks like you, would be talking about it. You prompted me to do my gene food panel, and my ABCG5 and my ABCG8 are not deviant. They're wild, so I can absorb my cholesterol in my gut through the Niemann-Pick-C1 receptor normally, but not excessively. But people can get tested for it. As you know, I just like putting nearly everybody on ezetimibe that needs cholesterol lowering, usually with a low dose statin, because that way we've covered the possibility that they're a hyperabsorber as well as being hyperproducer of lipids.
Yeah, so it's basically just throw Zeti in there in the toolkit. Yeah, I think that study, something like for there's a really large study that came out. It was like for patients with LDL cholesterol over 190 milligrams per deciliter, there was I was like, was it 7-8%, something like that, of them had testosterone in the 99th percentile, and it exists on a spectrum. So I think there's a lot of people out there who may have elevated phytosterols who don't know it, and then maybe their cardiologist is giving them a phytosterol supplement to try to block cholesterol absorption. Right. So it's if we're going to do personalized nutrition, I think it's something that's important to understand. But again, I mean, I'm on the front lines of it, and obviously pretty nerded out on it. So
I agree. Just maybe circling back, it's always a topic worth talking about, but the big name lipidologists, and you said one, Alan Snyderman, and I'm not particularly quoting him, but is that any rise in lipoprotein A from introducing a statin to a patient is not even worthy of consideration. Just get the LDL down. That's pretty much all we can do. If they have lipoprotein A inheritance, don't recheck it. It's not worth it. I mean, my experience is enormous that people come to me all the time. One way I have to do it, their lipoprotein A is 350 nanomoles per liter. That's a high level. That's 98th percentile or something. And they're on 40 milligrams of rosuvastatin. And I don't know what their baseline is, and neither does the patient. They've only had their blood checked once for lipoprotein A. So I will often, it depends, take them off for 4 weeks, recheck their blood. It's not uncommon to see their lipoprotein A drop to 220, like 40% drop. That's the opposite of knowing the baseline, starting the drug and rechecking it. There are big shifts in lipoprotein A from statins. I think less so if you're using what I do, 5 milligrams of rosuvastatin, 10 milligrams of ezetimibe. I've actually seen lipoprotein A drop on that combination, which it's not supposed to happen, but I see it happen. And there's at least one good study, prospective study, that if you have a patient with coronary artery disease, you start them on a statin and their lipoprotein A goes up, they're at higher risk for what we call an acute coronary syndrome. So I'm still just befuddled when you think back over the past 35 years, all these statin trials where lipoprotein A wasn't measured, but we know 20 to 25% of the people in the trial had elevated levels. If we could have segregated, in retrospect, let's take the lipoprotein A people out, I think we would have got much better statin results in those that are purely just hyperlipidemic. And we obviously need different strategies for the others. I just think it's such an intriguing, untouched topic.
Well, what do you do then? You just go to bempedoic acid and ezetimibe,
or you can't for insurance reasons. What I do the low dose combination, 5 and 10, and I might have to go up to 10 and 10. And I tend to use rosuvastatin, and ezetimibe, it's pretty typically 10 milligram dose. If they get side effects, then you can go to a PCSK9 and get both their LDL down and their lipoprotein A down. But insurance companies will shoot you down, and they'll shoot you down for Nexletol unless you really document statin side effects or statin ineffectiveness. I mean, that's what you do.
Well, that's a good. I mean, I appreciate the nuanced approach. It's nice to hear. I think that's one of the things that's lacking from our nutrition conversations are mirroring our political conversations, and there's a very tribal, I want to win kind of a vibe to all of this, right? Like just this siloed, very partisan conversation. So it's always good to have you on to get. You're a plant-based guy, but functional and open-minded and looking for different solutions. So it's always good to chat with you, and we appreciate your time.
Thank you, sir.
Yeah. Keep doing the great work that you're doing, helping people.
Just trying to learn and take good care of people. Thank you.
Thanks, Dr. Kahn.